Welcome to the 21st Century Man podcast. We're continuing our journey through the fantastic book, The 21st Century Man, exploring insights for modern well-being.
Indeed. And today we're tackling a really vital chapter, chapter 25, which focuses on preventing hearing loss.
Absolutely crucial. This chapter comes from Dr. Michael Murphy, who's an ENT surgeon, and Toby Hill, a hearing instrument specialist. So we've got some real expertise here.
Definitely. And they kick things off with a quote that really stuck with me from Mihaly Csikszentmihalyi. It's not the hearing that improves life, but the listening.
That really shifts the perspective, doesn't it? It's not just about the mechanics, but how we engage with sound.
Exactly. It sets the stage perfectly for what the chapter covers.
So in this deep dive, we're going to unpack that. We'll look at how our ears are structured, how hearing actually works, what can go wrong.
And importantly, what we can actually do about it, the practical stuff,
Right. We want to pull out those key facts and actionable tips directly from Chapter 25 so you, our listeners, feel equipped to understand and really take care of your hearing health.
Well, the chapter starts right off by hammering home just how fundamental hearing is. It's not just for, enjoying music or chatting with friends, although those are obviously huge for quality of life.
Yeah, things we might take for granted sometimes.
But it's also critical for safety. Think about alarms, car horns, sirens. Those sounds keep us aware, keep us safe.
That's such a good point. Safety isn't the first thing I think of with hearing, but it's vital. And the chapter, it paints a great picture of how hearing connects us,
Yeah.
right? To nature, music, relationships.
Absolutely. And conversely, they also talk about the impact when hearing isn't working well. Hearing loss can bring frustration, strain relationships because, well, communication breaks down.
Me myth things, maybe misunderstand.
Exactly. It can even lead to social withdrawal, people pulling back because it's just too difficult or embarrassing. And they touch on a potential link to reduced mental sharpness, too.
It really highlights how interconnected everything is. But there's good news too, right?
Yes, definitely. Chapter 25 is quite reassuring on this front. It stresses that most hearing problems can be diagnosed and treated effectively. That's a key takeaway.
Okay, that's encouraging. So to get into how we prevent and treat these issues, we probably need to understand the basics of the ear first, the anatomy.
Right, and the chapter breaks it down very clearly into three main sections: the outer ear, the middle ear, and the inner ear.
Okay, let's start outside and work our way in. The outer ear.
Mm-hmm.
That's basically what we see. Plus the canal leading inwards.
Pretty much. You've got the auricle or the pinna, that's the visible bit. Its job is like a funnel, collecting sound and directing it into the external auditory canal.
And that canal? How long is that typically?
The book says it's about an inch long and maybe a third of an inch wide. An interesting detail is that the outer part has cartilage, skin, those wax glands producing cerumen or earwax and hair follicles.
Ah, the wax glands. We'll probably come back to that.
We will, but the inner two-thirds of that canal is different. It's just skin directly over bone, making it really sensitive.
Which explains why sticking things in there is generally a bad idea.
Yeah.
Okay, so sound goes down the canal. What's next? The middle ear.
Correct. The middle ear starts right behind the eardrum, the tympanic membrane. That membrane is key. It separates the outer from the middle ear, and it vibrates when sound waves hit it.
So it turns sound waves into physical movement.
Exactly. It transforms the sound energy into mechanical vibrations. And those vibrations get passed along by three tiny bones, the ossicles.
The famous hammer, anvil, and stirrup?
That's them. Or, more technically, the malleus, incus, and stapes. The malleus is attached to the eardrum, the incus is in the middle, and the stapes connects to the inner ear at a spot called the oval window.
And the stapes. It acts like a piston pushing on the inner ear.
Precisely. That piston action creates waves in the fluid of the inner ear, which is the next step. But still in the middle ear, there's the middle ear space itself. It's air-filled, and the eustachian tube.
All right, the eustachian tube. That's the one that gets blocked when you fly sometimes.
Often, yes. It runs from the back of your nose up to the middle ear space. Its main job is to equalize the air pressure inside your middle ear with the pressure outside your body.
So when your ears pop, that's the tube opening.
That's Aduna's job. And the chapter points out that if that tube isn't working right, maybe due to a cold or allergies, that can cause problems, including hearing loss.
Okay, makes sense. Now let's go deeper. The inner ear. What's happening in there?
This is where the magic really happens, converting those vibrations into signals the brain understands. It's a complex, fluid-filled system. The main players mentioned are the cochlea and the semicircular canals.
Cochlea. That's the snail-shaped part.
Exactly, named after the Greek word for snail. It's filled with fluid and lined with thousands of tiny hair cells. When the stapes pushes on the oval window, it creates waves in this fluid.
And those waves move the hair cells.
Yes. And that movement of the hair cells triggers electrical signals that get sent up the auditory nerve to the brain. That's hearing, essentially. The cochlea sorts out the different frequencies, too.
Incredible. And the semicircular canals, they're involved too.
They are, but primarily for balance, not hearing. They're 3 fluid-filled loops oriented in different directions. They detect head movements.
So that's why inner ear problems can sometimes cause dizziness or vertigo.
Absolutely. The chapter mentions that connection issues in the inner ear can affect both hearing and balance. Dysfunction in the canals is a major cause of vertigo.
And there's also the internal auditory canal.
Right. That's the bony channel connecting the inner ear structures to the brainstem. It contains the nerve for hearing and balance the vestibulocochlear nerve and also the facial nerve.
Wow, it's such an intricate system packed into a tiny space. Understanding that anatomy really helps picture how hearing works.
It does. And the chapter then lays out the physiology, that step-by-step process, very clearly.
Okay, let's trace a sound wave. First, the outer ear collects it, funnels it down the canal to the eardrum.
Right. Step 1. Then step 2, the eardrum vibrates.
And those vibrations travel through the middle ear bones, malleus, umbilicus, stapes.
Yep, like a tiny chain reaction, amplifying the vibration slightly as it goes. Step 3 is the stapes pushing on the oval window of the cochlea.
Creating those waves in the cochlear fluid, that's step 4.
Step 4, yeah, and step 5 is those fluid waves causing the little hair cells, the cilia there are about 30,000 of them, to move or bend.
And that bending is what generates the electrical signal,
That's the crucial conversion, step 6. The bending creates electrical impulses.
which then travel along the cochlear nerve to the brain to be interpreted as sound. Step 7.
You got it, an amazing sequence happening constantly.
It really is. Okay, so now that we understand the how, let's talk about what happens when things go wrong. The chapter mentions different types of hearing loss.
Yes, it categorizes them mainly into conductive, sensorineural, and mixed.
Conductive.
Yeah.
Does that relate to conducting the sound through the outer and middle ear?
Exactly. It's an issue somewhere in that pathway, the ear canal, the eardrum, or those middle ear bones. Maybe wax blockage, fluid, damage to the eardrum, or problems with the ossicles.
And the good news there, the chapter says, is that these are often treatable, medically or surgically.
Often, yes. That's a key point about conductive loss. Sensorineural loss, on the other hand, involves the inner ear.
So the cochlea, those hair cells, or the auditory nerve itself.
Right. Damage to the hair cells is a very common cause. This type is usually permanent, unfortunately, though it can often be managed.
And mixed hearing loss is just a combination of both.
Correct. Someone might have, say, age-related sensorineural loss and a conductive issue like fluid in the middle ear.
Okay. So how do professionals figure out what type someone has? What's the assessment process like?
It usually starts with a good medical history and a physical exam by a provider. Looking in the ear is the first step.
And they might use tuning forks. I remember those from school.
Yeah, they're still used. Simple vibrating forks, usually 256 hertz and 512 hertz. They can give a quick initial sense of whether there's loss, maybe what type, and roughly how severe. It's a screening tool, really.
But for a proper diagnosis, you need the full audiologic assessment.
Absolutely. The chapter is clear. That's the only way to know your hearing thresholds accurately. They recommend getting a baseline test around age 50.
And that's done by an audiologist or a hearing instrument specialist in a sound booth.
Typically, yes.
Right.
By qualified professionals in a controlled environment. The assessment has several parts. First is otoscopy, visually checking the ear canal and eardrum again.
Looking for wax, infections, holes.
Exactly. Then comes the audiometric testing. This includes pure tone tests.
That's the raise your hand when you hear the beat test.
That's the one. They test different frequencies, from low pitch to high pitch, finding the softest sound you can hear at 50% of the time. That's your threshold.
And they do it with headphones. That's air conduction.
Right, testing the whole pathway.
Yeah.
Then they also use a bone conduction oscillator, a little device placed on the mastoid bone behind your ear.
Ah, and that bypasses the outer and middle ear to stimulate the inner ear directly.
Precisely. Comparing the air and bone conduction results helps identify that air-bone gap we mentioned, which points towards conductive or mixed loss.
Okay, that makes sense. What else is involved in the assessment?
Speech audiometry is also really important. One part is the speech reception threshold, or SRT.
How is that different from the pure tones?
Instead of beeps, they use simple two-syllable words like baseball or hot dog and find the quietest level you can repeat them correctly half the time. It helps verify the pure tone results and gives an idea of comfortable listening levels.
And then there's word recognition.
Yes, the word recognition score, or WRS. Here, they play single-syllable words at a comfortable loudness and see what percentage you understand correctly. This assesses clarity, not just volume.
Why is that important?
It gives insight into how well you might do with hearing aids, and can sometimes even indicate issues further up the auditory pathway, like with the nerve. The chapter notes using record speech is the standard for consistency here.
And sometimes they test hearing and noise.
Yes, speech in noise, SIN testing, is increasingly common. They see how well you understand speech with background chatter like multi-talker babble.
Simulating a noisy restaurant or party.
Exactly. This helps determine your signal-to-noise ratio, or SNR loss, which is crucial for choosing the right hearing aid technology and setting realistic expectations for noisy places.
So all that data gets put together.
On an audiogram. That's the chart showing your hearing thresholds graphically, along with the speech test results and usually recommendations. But as the book notes, not everyone with hearing difficulties needs or will benefit enough from hearing aids to justify the cost. Other options might be explored.
Right. Okay, let's move into treatments, starting with the outer ear. You mentioned earwax earlier. Cerumen impaction.
Yes. Earwax is actually normal and protective. It lubricates, cleans, traps debris. Jaw movement usually helps it migrate out.
But sometimes it builds up too much.
It can. Impaction means it's causing symptoms. Fullness, itching, maybe pain, dizziness, even a cough. And definitely hearing loss. The book says it can reduce hearing by 5 to 40 decibels. It can also mess with hearing aids.
So when do you need to get it removed?
Treatment's needed if you have symptoms or if hearing loss is suspected, especially in people who can't easily report symptoms, like some elderly folks or young kids.
And who does the removal?
Primary care providers, nurses, audiologists, hearing aid specialists can often do it. An ENT might be needed for really impacted cases. The key, stressed in the chapter, is using proper tools and techniques to avoid injury. You don't want to cause cuts, infection, or perforate the eardrum.
Definitely not a DIY job with a cotton swab then.
Please no. Okay, moving inward to the middle ear. We talked about the eustachian tube. Dysfunction there is common.
Caused by colds, allergies, sinus issues, even acid reflux, the chapter says.
All of those, yes. Also, barotrauma pressure changes irritants like smoke or even growths like polyps or enlarged adenoids. It causes that blocked feeling.
And that can lead to otitis media, the middle ear inflammation.
Right. There's acute otitis media, AOM, the painful ear infection common in kids, and then otitis media with effusion, OME, which is fluid buildup without acute infection.
OME might happen after an infection clears up or due to allergies.
Exactly. Symptoms are usually fullness, pressure, maybe some crackling or popping, and mild to moderate conductive hearing loss. Usually no pain, though. The eardrum might look flat or have fluid bubbles behind it.
How is OME treated?
The first step is often treating the underlying nasal issue, maybe with a nasal steroid spray like Nasacort or Flonase for a couple of weeks. Oral steroids might be tried if that fails.
And if the fluid just won't clear?
Then an ENT referral is needed. They might perform a myringotomy, a tiny cut in the eardrum to suction out the fluid. Sometimes they place a small ventilation tube, an ear tube, to keep it draining and aerated.
Okay. What about issues with the middle ear bones themselves? The chapter mentions otosclerosis.
Yes, that's a condition where there's abnormal bone remodeling, often affecting the stapes, the stirrup bone. It can become fixed, stuck, so it can't vibrate properly.
Leading to conductive hearing loss.
Yes, often progressive, sometimes leading to complete conductive loss. It usually starts in young adults, 20s or 30s, and there's a strong genetic link, about 60% of cases.
How is that managed?
Initially, hearing aids can work well. They monitor it with regular hearing tests, but if it progresses, surgery is an option. A stapedectomy or stapedotomy replaces part or all of the stapes bone. Success rates are high, over 90%, though there's a small risk, about 1%, of making the hearing worse.
And finally, for the middle ear, eardrum perforation, a hole in the eardrum.
Right. Caused by infection, trauma like a Q-tip injury, sudden pressure changes, or a blow to the ear. Hearing loss depends on the size and location.
Does it need treatment?
It needs prompt medical attention. Small holes might heal on their own, but if not, a surgery called tympanoplasty can patch the eardrum.
Okay, that covers the middle ear pretty well. Let's shift to the inner ear and neurological issues. Sensorineural hearing loss, SNHL.
This is where damage occurs in the cochlea, the nerve, or the brain pathways. Often it's damage to those crucial hair cells in the cochlea.
And the most common cause is just aging. Presbycusis.
Yes, age-related hearing loss is the most common. It typically affects high frequencies first, making it hard to hear in noise or understand speech clearly, even if it's loud. Tinnitus, that ringing or buzzing, often accompanies it and seems worse in quiet.
Another major cause mentioned is noise exposure, right? Noise-induced hearing loss.
Hugely important and often preventable. The chapter states about 24% of adults show signs of it. Very loud, sudden noises, firearms, loud concerts, even some sporting events can cause immediate damage.
So earplugs or earmuffs are essential in those situations.
Absolutely critical. The chapter mentions average levels at sporting events being 81-96 dB, with peaks much higher. Anything over 120 dB is instantly risky.
What about ongoing noise like at work?
Occupational noise is also a big factor. OSHA has guidelines for workplaces. If noise levels are over 85 decibels on average, hearing protection and a monitoring program are required. There are limits on how long you can be exposed based on the loudness. Louder means less time is safe.
Good to know. The chapter also mentions medications causing hearing loss. Ototoxicity.
Yes, certain drugs, including some powerful antibiotics and chemotherapy agents, can damage the inner ear structures. It often starts as high-frequency loss and can get worse. Always worth asking your doctor or pharmacist about potential hearing side effects of new meds.
Definitely. What are some other specific inner ear or nerve disorders covered?
Well, there are tumors, like vestibular schwannomas, also called acoustic neuromas. They're usually benign, growing on the balance part of the nerve.
And they cause hearing loss?
Typically asymmetric loss worse in one ear, maybe tinnitus, dizziness, or balance issues too. An ENT evaluation is needed to rule this out if you have one-sided symptoms. An MRI is the best test for diagnosis.
Okay. What about Meniere's disease?
Meniere's involves excess fluid buildup in the inner ear. It causes sudden attacks, episodes of hearing loss, fullness, tinnitus, often combined with intense spinning vertigo. These attacks can last hours, with milder symptoms lingering. Again, prompt evaluation is key.
And the chapter specifically calls out sudden hearing loss as needing urgent attention.
Very strongly. This is a rapid, significant drop in hearing in one or both ears, could be conductive, sensorineural, or mixed. It requires immediate medical evaluation.
Why the urgency?
Because it could be caused by serious underlying issues like an autoimmune disease, Meniere's, stroke, MS, or that vestibular schwannoma. Also, treatment, often with high-dose steroids like prednisone, is most effective if started quickly, ideally within 2 weeks.
So see a doctor right away, get a hearing test ideally within days.
Yes, and they might consider other treatments like hyperbaric oxygen or steroid injections into the ear if oral steroids don't work or can't be given. And again, an MRI is needed to properly rule out tumors, as CT scans often miss them.
Okay, that's a lot of potential issues, but also treatments. Now, what about when hearing loss is present and amplification is needed? Hearing aids.
Right. The chapter moves into hearing assistance, and the technology has come such a long way.
It's not like my grandpa's bulky old hearing aid anymore, is it?
Not at all. Modern aids, especially the receiver in the ear or RE style, are tiny, discreet, and packed with features like low-energy Bluetooth.
So you can stream music or calls directly from your phone.
Exactly. Hands-free calls, direct audio streaming. It integrates seamlessly with other tech. And they're incredibly smart.
Oh, so.
They have sophisticated classifiers that analyze the sound environment constantly. They can identify speech, noise, music, quiet, and automatically adjust. They can activate noise reduction, focus microphones directionally.
So in a noisy restaurant, they can help focus on the person you're talking to.
Precisely. Some have specific restaurant modes. The chapter even mentions that some wearers with advanced tech might hear better in noise than people with normal hearing.
Wow. How do they actually work, in simple terms?
You've got a microphone to pick up sound, that classify processor chip to analyze it, an amplifier customized to the user's hearing loss based on their audiogram, and a receiver speaker to deliver the amplified sound into the ear canal. It all happens in milliseconds.
And there are different styles.
Lots of them. Behind the ear, BTE, the popular RI, custom ones that fit entirely in the ear, ITE, ITC, CIC, even invisible ones, deep in the canal, and extended wear options you leave in for months. The choice depends on hearing loss, ear shape, lifestyle, dexterity, budget.
The chapter also mentions PSAPs, personal sound amplification products.
Yes, those are more for people with normal hearing who just want a boost in specific situations, like meetings. They're not customized like hearing aids. And it also covers bone-anchored hearing aids, BAHA.
Those are surgically implanted.
Yes, for significant conductive loss. A small implant vibrates the bone, sending sound directly to the cochlea, bypassing the outer middle ear.
And for very severe sensory neural loss, there are cochlear implants.
Right. These also involve surgery. They bypass the damaged cochlea entirely and use electrodes to directly stimulate the auditory nerve fibers. It doesn't restore normal hearing, but with training, it allows users to understand speech and perceive environmental sounds, which is life-changing for many.
It sounds like there are many options available, depending on the type and severity of loss.
There really are. Technology has opened up so many possibilities.
So as we wrap up our discussion on Chapter 25, what are the main takeaways the authors want us to remember?
Well, first, just understanding the basics of your ear and how hearing works makes you a better advocate for your own health. Being informed helps.
Definitely. And the point about treatability.
Yes, many medical causes of hearing loss are treatable, especially if caught early. Don't ignore symptoms. While sensor neural loss can't usually be cured, modern hearing aids can drastically minimize the negative impact on your life.
So the core message is, be proactive.
Absolutely. Protect your hearing from loud noise. That's prevention. If you have concerns, get evaluated promptly by a competent provider, and know that even if traditional aids aren't enough, other options like surgery might exist.
This chapter in the 21st Century Man is just packed with valuable, practical information. We really do encourage everyone to read it fully.
Couldn't agree more. It's a fantastic resource.
Well, hopefully this deep dive has shed some light on this important topic for you. Remember, protecting your hearing is crucial, and help is available if you need it. Don't delay seeking advice if you have any worries.
Sound advice indeed.
Okay, that brings us to the close of this discussion. Thanks for tuning in to the 21st Century Man podcast.
We hope you found this exploration of Chapter 25 on preventing hearing loss useful.
Join us next time as we continue our journey through the book, delving into Chapter 26, Stronger Bones. Until then, take care.